Welcome, everybody, to the second of a two-part webinar series on the implications of the Camden Coalition's randomized controlled trial results. We are delighted to be co-hosting this event and really providing a forum for Camden's consumer scholars to share their perspectives with us. I have the great honor only of being the sort of very light MC today. And in that role, I just want to note that the session is being recorded, and a link to the presentation recording will be made available, will be sent to all registrants and posted on the Siren website when it's available. During today's event, we welcome your questions and comments. We ask everybody to use the Q&A function, not the chat function, so not what you're used to doing, but the Q&A function in the webinar features panel to ask any questions. The team has a great plan for getting to as many of those questions as possible. I have one other thing to tell you, and then we'll get to the main event. I just want to alert everybody about our next webinar event, which is titled, as you can see, Where Should the Healthcare Sector Invest in Food Security Interventions? So Lessons from Recent Research. So that event is scheduled on June 5th. You can use the QR code to link to the registration page, or you can just check out our website and we have the registration information available there too. It should be really lively, another great event, and hope you can join us. Great. So now back to the main event. So again, we are joined today by Camden's consumer scholars who are going to talk about the implications of the Camden Coalition's randomized controlled trial. So here's the brief scoop for those of you who need the reminder, which I always do. So in 2020, a really big splash, major article on healthcare hotspotting probably caught your eye. It definitely caught my eye. The article described findings from a 4-year prospective 800-person randomized trial describing the Camden Core Model, which is an incredibly innovative and comprehensive approach to care coordination for patients with very high use of healthcare services. And the study at the time, the first study, found no differences in healthcare utilization between patients who were randomly assigned to participate in that core model and those who received usual care. But then in 2023, there were 2 more studies published on the model looking in more detail at intervention dosage and intervention engagement. And these subsequent studies really helped to explain the original RCT's primary findings. So in today's conversations, we get a chance to ask whether and how those findings align with the perspectives of consumers and patient advocates. So Don Wiest, the Director of Research and Evaluation for the Camden Coalition, is going to moderate today's conversation with 4 national consumer scholars. Thank you so much for joining us today. Advocates and activists with lived experience with complex health and social needs. And I think you guys are scattered all over the country too. We're really delighted to hear your reactions and reflections about these findings. And Dawn, I will let you do a little bit more framing for us, and then we'll have the panelists introduce themselves.
Thanks so much, Laura, and to the entire Siren team for inviting us, and especially the consumer scholars, to reflect on the Camden Coalition RCT findings and the future of complex care research. I'm gonna, in a few minutes, share a very brief summary of the findings from that initial RCT study and then the follow-up studies. But before we get there, I want to turn it over to the scholars to introduce themselves. Pamela, would you like to start? And Dylan, if you could take that slide down, that'd be great, if we could see the consumer scholars on screen.
Thanks, Dawn, and hello, good day to everyone across the country. Really excited to see so many participants. I'm Pamela Corcoran. I'm a resident of the Penobscot Nation in the unceded Wabanaki Territory, also known to folks as Maine, USA. Live very close to the Canadian border in a very small town of about 6,000 folks. And I'm joining the conversation and excited to be here because I have had a set of circumstances that make me uniquely qualified, I think, to talk about some of the features that are in this research. I was a caregiver for over 20 years for 2 family members who experienced extreme cancer journeys, and I myself in 2022 joined them. We have a hereditary biomarker that I was fortunate enough to be able to discover. So my own care now is looking forward to some of the innovations and supports that complex care requires. I would say that the most important contribution I'd like to make today is that I also have a 35-year career at the intersection of community health and social justice. So pleasure to be here. Thank you.
Thank you, Pamela. Nora?
Hi, good morning, good afternoon, all. My name is Nora Gutierrez. I live in the Miami area in South Florida, and I am a patient advocate for my father. He's in the 80s, and he was scheduled for a stent surgery. Unfortunately, he had to undergo triple bypass surgery. And while at the hospital, we had obviously multiple treatment specialists, and we received conflicting information in terms of his hospital discharge readiness. He was discharged, and we got home, and then the nurse at our home care advised that he has complications and we need to take him to the emergency room. And so unfortunately, he was readmitted and was able to get the care that he needed for his recovery.
Thank you, Nora. Emily?
Hi, my name is Emily Cowan. I'm from Bloomfield, Connecticut. I'm a part of National Consumer Scholars. I am a disability advocate for over a decade, which is partly why I wanted to join this webinar. Oftentimes, healthcare professionals do not treat disabled people like a normal human being, so I am always trying to educate people on disability.
Thanks so much, Emily. Carl?
Hello, everybody. It's great to see everybody here. My name is Carl Boyd, and I'm a national consumer scholar with the Camden Coalition, and I happen to live in Camden City or Camden, New Jersey, where the coalition is at. I've experienced, I have lived experience with heart issues, as well as I went through a really severe bout with COVID pneumonia, where I almost died. So with all those health complications, and looking at this study, I'm really interested in the question you asked about admissions and readmission rates, because to me, readmissions are considered to be bad, but these rates are, to at least in my respect, I consider it to be person by person, because everybody uniquely goes through their experiences, just due to how sick they are, or due to what's going on with them at the time. And I was kind of saying, the readmission rates are considered to be bad, and we slap our hands sometimes because, oh, we got all these readmissions. But I think we just really need to dig deeper on an individual level. So this is going to be an interesting call to see the different perspectives about this, and I look forward to a really good dialogue with everybody.
Thanks so much, Carl. Really appreciate you all being here today. And before I share a summary of the findings and get to the discussion with the consumer scholars, I'd like to introduce Evelyn Kane, who is the Camden Coalition's Associate Director for Community Engagement and Capacity Building. She'll speak a bit about our organization's initiatives involving individuals with lived experiences. And Alex, if you want to put that deck up, that'd be awesome.
Hi, everybody. Thanks so much, Dawn. So like Dawn mentioned, my name's Evelyn Kane. Honored to serve as the Associate Director for Community Engagement and Capacity Building at the Camden Coalition. I'm really excited for the panel conversation today, so I'm only going to take a minute to talk about the Camden Coalition's approach and work in community engagement. So at the Coalition, we believe that people with lived experience are invaluable partners in all aspects of complex care work, from program planning and design to leadership and governance, research, evaluation, systems change, policy work, and as members on care teams in roles like community health workers and peers. Those with firsthand lived experience as people who have actually navigated health and social care systems for themselves and for their families understand what challenges folks like them face and what solutions will actually best address their needs. And so our community engagement work at the Coalition spans from our local to our regional to our national work. Locally in Camden, New Jersey, we engage and partner with community residents and graduates of our care management program through our Community Advisory Committee. And leadership of our CAC sit as members on the Coalition's Board of Directors. An initiative that we co-designed with folks who are part of our CAC is the Community Ambassadors Program, where we work with folks in trusted messengers roles who share public health information out into their communities and bring lessons from their work on the ground back to the Coalition and our state and local partners. And then nationally, we operate the Consumer Scholars Program, which is a peer learning and leadership development program for folks with complex health and social needs who are doing amazing grassroots leadership work in their respective communities. And of course, our panelists are all members of the current Consumer Scholar cohort. We also operate our Consumer Voices Bureau, Amplify, where we help organizations all across the country to build impactful and inclusive partnerships with people with lived experience. So for all of you who are in attendance, who at the end of the session will be left thinking, how can I and my organization partner with folks like Pamela and Carl and Nora and Emily? Please reach out to us through Amplify and we can help you to do just that. And lastly, the Coalition is a proud member of the Inspire Project, which is a team of national organizations and people with lived experience who are working side by side to initiate national strategies to advance the practice of community engagement in healthcare. So there's so much more I'd love to share about the work, but I'll leave it there. If you're interested in learning more, you can head over to our webpage, camdenhealth.org/community/engagement. I'll drop that into the chat in a second, where you can read more about the programs I mentioned, and there's many resources that are available to you there as well. And if you are interested in connecting about any of the work, or if you'd like to follow up on the panel discussion today, you can feel free to email me at ekane@camdenhealth.org, and I'll drop that in the chat as well. And I look forward to the conversation.
All right, thanks so much, Eveline. I know that many in the audience joined the first part of this webinar series on the Camden Coalition, but I'd like to spend 5 minutes or so summarizing the findings of that initial research and the follow-up studies for those who are unable to join that webinar, and then we'll move into a conversation with our consumer scholars. Next slide, please. So in 2014, the Camden Coalition partnered with JPAL North America to conduct a randomized controlled trial of the Camden Core Model, which is a care management intervention designed to improve the health and well-being of individuals living with complex health and social needs. The RCT enrolled 800 individuals at hospital bedside who are identified as eligible for the Core Model intervention, with roughly the same number randomized into the control and intervention groups. These individuals ranged in age from 18 to 80 years old. They had at least 2 hospital admissions in a 6-month period, 2 or more chronic illnesses, and evidence of other complexities such as difficulty accessing services or lack of social support, a coexisting behavioral health condition, or housing instability. So after discharge from the hospital, the patients enrolled in the intervention arm of the trial worked with an interdisciplinary team of nurses, community health workers, social workers, health coaches, for approximately 90 days in the community. So the care teams conducted home visits and coordinated follow-up care and relevant services in the community. They helped patients apply for benefits, and they coached patients in various health strategies such as medication reconciliation and management and blood sugar monitoring. The care teams prioritized building genuine relationships with their patients, and they supported them as they strove to achieve their health-related goals that were based on a personalized care plan. And throughout the study, the Camden Coalition evolved the core model as we learned more about our patients and the circumstances they were facing. So for example, we adapted the model to include housing first, a medical legal partnership, and closer ties to behavioral health providers in the region. Next slide, please. The primary outcome studied in the RCT was hospital readmissions 180 days after discharge. Prior to the RCT, there was evidence for reduced readmissions among intervention participants, and we did see that same decline in the RCT. This plot shows the decline in the average number of readmissions over the first and second quarters after initial hospital discharge. And that peak that you see in hospital admissions just before study enrollment reflects that eligibility criteria of 2 or more admissions prior to enrollment in the core model. Next slide, please. But when we compared the intervention participants to individuals randomized to the control group, that decline in readmissions was similar. Both groups averaged about the same number of hospital readmissions. They had similar readmission rates. And so the researchers concluded that the core model had no impact on reducing hospital readmissions for people living with complex health and social needs. Next slide, please. So we partnered again with JPAL North America and with Rutgers Center for Health, State Health Policy to conduct additional analyses of the RCT data. And this time we focused on Medicaid beneficiaries and incorporated Medicaid records on non-hospital use into the analysis. By studying timely access to follow-up care, the researchers sought to shed light on the question of whether the initial study's null result was an outcome of poor intervention implementation or an incorrect theory of change. This study replicated the findings of no difference in hospital readmissions between control and intervention groups, and also found that there was no difference in emergency department visits after enrollment. The data did show, however, that the Camden Core models were very successful at connecting the intervention participants to ambulatory care in the community. While under 30% of the control group attended an appointment with a primary specialty care provider within 14 days after hospital discharge, that percentage for the intervention group was around 40%, a little bit higher than 40%. And 1 year after that initial hospital discharge, the intervention group averaged a higher number of visits with primary or secondary care providers in the community. The other finding that I should mention here is that the study found that there was higher access to durable medical equipment, such as wheelchairs or oxygen supplies for the intervention group. And with all of that in mind, the researchers concluded that the core model was implemented well, but that care management was not sufficient for reducing hospitalizations within such a complex population. Next slide, please. Just a few more studies I'd like to focus on here before we move to our conversation. Additional analyses focused on variation in the amount of intervention received by individuals who were randomized to the treatment arm of the trial. There was a lot of variability among participants in the number of direct contact hours with staff or care coordination hours spent by care team staff, and patients with more staff contact had significantly lower readmissions. So we partnered with Kaiser Permanente researchers to look into this using a robust statistical methodology that allowed us to analyze subgroups of control and intervention group patients based on their predicted level of engagement in the intervention. Data collected prior to study enrollment were used to build a model of engagement among intervention patients, and then used to predict levels of engagement across the study population using a machine learning model. So the charts on this slide show incident rate ratios for readmission counts between intervention and control groups, and odds ratios for readmission rates within increasingly distilled samples. And what that means is that from the left to the right, we have on the left-hand side the full study population. By the time we get all the way to the right on these charts, we're down to that 20% of patients who had the highest probabilities of participation in the intervention. And what we see is a downward trend in the estimates and confidence intervals representing greater intervention effectiveness among individuals with the highest probabilities of participation in the intervention. For example, in the subgroup most highly concentrated with likely participants, representing 20% of the full study population, the 30-day readmission rate for the intervention group was 19% compared to 31% for the control group. And next slide, please. And this will be the final slide for describing some of the results from the follow-up analyses, and then we'll move into a conversation with the consumer scholars. The distillation analysis also helped us identify characteristics associated with higher and lower higher and lower intervention participation. So this graph shows the percentage of patients with each listed characteristic within the full study population, represented by the gray bar, and within the subgroup with the highest concentration of engaged patients, or 20% of the full population, represented by the red bar. And here I'll briefly highlight 3 characteristics associated with lower levels of engagement in the intervention. So individuals experiencing homelessness made up around 10% of the full study population, but only around 4% of the engaged subgroup. Patients with any arrests in the 6 months prior to study enrollment made up 6% of this full population, but were not at all present in that subgroup with the most highly engaged participants. And finally, while patients with a substance use disorder represented around 1/3 of the full population, they comprised about 1/4 of the highly engaged subgroups. Okay, so hopefully that wasn't too fast for y'all. That was a very high-level summary of the studies. And Alex, if you wouldn't mind taking the slides down. Okay, so Carl, you sort of got us started with this in your introduction, but I'd like to talk about this outcome measure of readmission. So this was the primary outcome of the Camden Coalition RCT. And we've always said, since that time, since the study was published in 2020, that if we were to conduct another RCT, we'd include additional outcome measures, and we'd prioritize those that were important to patients. So I'd like to hear your perspectives on how we should measure success in healthcare. For example, are readmissions a good indicator of healthcare service quality and effectiveness from your perspectives?
Okay, so the way I'm looking at this is readmissions to some level can be that, but I go back to, we have to take this person by person. Everybody's lived experience is different. So let's say that all the consumer scholars had the same lived experience. Let's say we all had heart problems. Even though it's the same in reference to the problem, we would still each have a different lived experience, because everybody's body is different. Everybody's circumstance is different. There's a lot of other things that have to come into play in order to look at that person and kind of see why they're coming back and forth to the hospital. So while I think that that's a factor, I think that there are other factors that you have to play in and put together, with that. And did you have another question to that? Was that the base question that you had?
That's good. I mean, one of the questions that's related to it is what are we actually learning when we study readmissions? What does a readmission mean? And is it an indicator of healthcare quality and effectiveness?
Well,
and I think Pamela, go ahead, Carl. Sorry.
Well, I'm just going to say, and then I know Pamela needs to go, that when you pulled up the engagement matters piece, that was super important to all of this. That kind of follows part and parcel to what I'm saying. If you just look at a readmission, just specifically that person coming in, you're not going to get much data. The data comes from the engagement piece, where we all have to participate, where you kind of develop a fast track relationship, like you do your elevator pitch, and you develop that relationship in order to get more out of the patient, and the patient then starts to trust the doctor and the nurse to get what they need out of them. I think that when you do the engagement piece, without the engagement piece, you really don't have the data that you need to kind of move forward and to treat people robustly. So I think that piece matters, and I'm going to kind of hand it over to Pam, because we had some discussions the other day, and I think she's going to dig a little deeper into that piece.
Well, Carl, that's probably the phrase that we need to look at when we consider this really good summary that we had from Dawn, and then also the prior seminar or webinar about this data set. So here's what I want to say. one of the things that brought the four of us together, and we are just a small group of the National Consumer Scholars, is we all were centering curiosity about what can we learn? Because Dawn was a presenter at one of our sessions, and I think some people were almost jumping out of their chairs wanting to say things about what it's like from their lived experience, their sense of their community, their sense of the healthcare system, their sense of our national challenges and opportunities. So I want to jump in and just kind of bring the microscope down a little and talk about what's happening in my community. I don't think my community is unique, but I think I can speak authoritatively, and it may give you, as webinar participants, some food for thought about what you're considering as a policymaker or as a practitioner or as a regulator, or perhaps we're joined by other folks with lived experience of complex care. Let me start out by saying some things, and I promise I'm not misspeaking. In our whole county, which is bigger than most of the cities in the country, we have only one hospital. Our one hospital is licensed for 25 beds. Through COVID and going out of COVID, typically our hospital has approximately 10 beds for inpatient care that are staffed. A lot of travelers coming through here to support the effort. So what that means specifically is our hospital is designated as a critical access hospital. And as a result, there's some requirements that Medicare imposes to make sure that the preferential way our hospital gets paid, which means on a cost-based reimbursement, is that our average patient's stay cannot exceed 96 hours, or we lose that source of very critical revenue. And I've learned specifics about that, but I won't go into it as it relates, to trying to look at the broader thing. So when I heard that the top level interpretation of the theory of change, or the hypothesis in this study, was, in essence, we want to see readmissions go down. That doesn't really fit in our experience, our environment, in terms of supporting our very small hospital. And just as I mentioned in my introduction, we have roughly 6,000 residents in our town. So imagine the scale differences. So specifically, with folks coming in with 3+ chronic conditions, we heard, or 2+, I think, in the study design, or coming in with financial barriers to care, the challenge really becomes, are we looking at the right thing? And I believe when we had our further deep dive into the data, we saw we weren't really looking at all of the drivers of change, as Dawn put out specifically in those subgroups. And I would say the other piece that's really important that I want to report on is not only would the way that folks in my community and the way I myself have been able to connect with the hospital system, is that we don't have the array of resources, community-based resources that are present in lots of other communities, And so those things affect where we go to for almost functionally primary care in many cases. And I would just leave with the notion that my biggest takeaway is it was really great to have the result of learning that readmissions weren't the biggest driver of change. And secondly, that we need to look at our individual circumstances or communities when we begin to build solutions that will hopefully drive change at the national level. So I'll be quiet there and look forward to jumping in again with further questions.
Yeah, Pamela, thanks so much. That's a great point you make there around looking at our individual communities. The coalition, we increasingly speak of ecosystems of care, right? It's not, the ecosystem available to individuals who are, going to the hospital or have a healthcare concern varies tremendously across place. So place is such an important factor, and I really appreciate you bringing that up. Nora, would you like to share your thoughts on this question of readmissions and measuring success in healthcare?
Well, in my particular case, we were relying on the medical professionals to be able to provide the care for my father. And when obviously we didn't question it. So that ended up being for us a situation where my father had to go back to the hospital and to receive treatment. And piggybacking on what Carl and Pamela said, we really need to look at the individual situation in terms of the community. What is it that we are trying to reduce? And I know that in that case with my father, because of his age, they were looking at, well, we need to discharge him as soon as possible because we don't want there to be any additional infections or respiratory. But unfortunately, that ended up him having to come back. So sometimes when they look at the individual care for that patient, they lose the fact that that decision to have discharged him earlier really impacted his recovery.
That's great, Nora. And I think we talked, or I do remember us talking a bit about how we share those similar experiences as caregivers. For example, I experienced it with my mother very recently with a hospital discharge that happened too soon. And then she ended up going back to the hospital. So it becomes very complicated when we talk about readmissions and what they actually mean, what they actually measure. Emily, I recall during our conversations, you had some really great insight, and especially in response to a question that had come in from one of the registrants around what should we be measuring? And one of the registrants had asked when we're speaking specifically about people who have disabilities, what should we be looking at? What should we care about? What should we measure?
When it comes to measuring success in healthcare services, I think one of the most important outcomes to measure for disabled people specifically is to see if they feel like they are being heard. Oftentimes, medical professionals don't speak directly to disabled people. They speak to whoever is with them because they assume that disabled people don't understand and cannot communicate for themselves. Another important outcome that I think is important to measure is if they feel like medical professionals respect their autonomy.
Great. Thanks so much, Emily. And what you just spoke of really gets at this question of engagement as well, right? So as you mentioned, if a provider is not looking at you or speaking directly to you, I mean, there goes any potential for building trust, right? And one of our follow-up studies showed how important engagement is. And it seems almost like a no-brainer in some ways, right? I mean, engagement, of course, somebody has to be there participating in care for there to be any result. But I want to ask you all, and some of you touched on this a bit, we found, so for just to refresh everybody's memories, like some of the things that we found in the follow-up study was housing instability sort of was a predictor of lower engagement in the intervention. Having a criminal justice history was a predictor of lower engagement. What are your thoughts on other barriers to optimal engagement in healthcare interventions or programs? And what are some strategies you think that providers should adopt to really enhance a person's ability to engage in their care?
I'm going to respond to that. So, when I went through COVID pneumonia, I was in 2 hospitals and a nursing home. So I wasn't at home for a full year, and I didn't go back to work until like a year and a half later. So with that, you already know that there's a lot going on. Everybody, the whole world was upside down. And I'm going through the pandemic in the worst way. Luckily, I'm here, and thankfully I'm here, and I credit a lot of medical professionals, and I credit people in the community and family for me to get back to where I am. So with that being said, you need a community. So it's not just doctors or nurses. It's also your family. It's also your friends, but it's also those people that are, maybe not doctors, but maybe CHWs, social workers, and people that, you almost need like a coalition around you. Camden Coalition, no pun, but you need a coalition, your personal coalition. So being able to effectively communicate with doctors and nurses, and just everybody communicating on a human level. Everybody is, not built the same, and everybody doesn't have the capacity to kind of take down their engagement to a personal level. But if you have those different partners in place, that communication from the doctor to you can message well. Just the ability to look at another human being and say, oh yeah, they're going through this, and I feel for them, and having one-on-one conversations, having not just respect, but mutual respect, being able to, like, when doctors and nurses and different people came, I asked questions all the time because I wanted to be informed about my condition. And I've said this to you all. My thing is, you need to have that group, but I was always of the admission of, how can I help you to help me get better? So it's not just going to be, oh, okay, so come in, sign this, take a pill, this, that, and the other. I work as a community liaison, so I already went in engagement ready, and everybody is not like that. But I'm like, no, engagement does matter, as you said earlier. Engagement and proper engagement, authentic engagement is the key to bringing some of this together. Yes, there's the medical piece, but you have to bring these other pieces in order to, like I said, help me to get better. So that's just kind of my spin on it.
Right. I want to talk about some of the barriers, kind of piggyback on what Emily said, that my father's had several orthopedic surgeries, and time again, I see that the doctors come in, and sometimes it could be because of language barrier. My father does understand English, but most of the time I'm translating, and they will talk to me directly. And so I try to look down, try to avoid eye contact. I try walking closer to my dad, so that they can talk to the patient and provide that exchange of information. And like Carl, I like to ask questions. And so I guess maybe they look at me because I'm asking those questions, but sometimes they just totally, the ignore the patient and they go directly to the caregiver. And that obviously makes my father very uncomfortable. And they need to be talking to him because he's the one that can provide where he is in this medical recovery. And also there isn't, like Carl said, there isn't the rapport. They just come in, look at the chart, walk out. And so sometimes the family members as well as the patient are like, what is my status? And that's very uncomfortable. And more importantly, it doesn't really help the recovery while you're in the hospital.
And Nora, I'm sorry. And Nora, I just, speaking on that, and that's why I came in. Like, there was a time where when I was in the hospital, I was sedated, so I couldn't speak for myself. Luckily, I had good medical people, and I had my family to be able to speak for me. But when I was able to speak for myself, when I wasn't sedated, I knew it was my job also as the patient, because I'm not going to leave it all in the medical people, medical professionals. It's my job as a patient to get to work on building that rapport, because to me, that rapport was just as critical as the life-saving medicine or treatments that they gave me.
That's
Great,
really
thank you.
that foundation of respect for the different folks that are all committed to optimizing health and well-being. And when we can center the patients, I also want to say we're centering the folks that pay the bills, whether it's directly out of our own pocket, which a lot of us did for many years before we had the Affordable Care Act or the Medicaid expansion programs. So when we look structurally or from a policy point of view, it's really key to remember that we've built our systems based on serving members of our community or patients. And the more we can center and remember that expertise, the more effective and the more capable we'll be at improving our health, our public health and well-being. And I guess I just want to go back to the amplification of the data set. It's if I got the numbers right, and I'm thinking clearly, we saw our best results in terms of looking at the study. I think it was the third time when we could see that the folks that had diabetes problems, the folks who couldn't breathe, the folks who had kidney problems, and had that kind of intervention of care management, of advocacy, the better results we had in terms of readmissions. And complex care is challenging. I mean, Carl was very transparent, and I appreciate what he, was saying about his own journey. Prior to my cancer diagnosis, I brought in a CPTSD, as well as 3 chronic conditions. And if I'm essentially depending on a hospital for primary care, where do you start the story to try to adjust and manage? You don't take care of all of that in one sitting, but by any means. But then in addition, I have the further challenge that to seek specialized care for nephrology, for cancer care, I'm having to travel over 2.5 miles to 2.5 hours, miles and miles, over 100 miles to see specialists. So, how can we optimize the best way to do that resource navigation, both from a continuity of care, from the compassionate work and strong capability of the providers to discern how we prioritize care, and then finally, where's the follow-up and the support to be able to stay compliant with our medications, with the other interventions that'll keep us, thriving. And frankly, do that under the pressures, the extreme pressures of financial viability for the roughly 40% of the people in the country that live in rural areas, which don't often get elevated in these kinds of policy considerations or evaluations of data sets. So
thank you, Pamela. I wanted to so we're talking a lot about the medical aspects, and obviously that's a hugely important and should be elevated, like the complexities that people face in terms of their medical challenges. There's another piece of this, and that is, again, when we saw, for example, that people experiencing homelessness had lower levels of engagement. The other aspect is social needs, right? The ability of healthcare providers to connect people, or to even understand and see and try to address a person's social circumstances. What are your thoughts on that? What this actually ties into a question that was asked by one of the registrants about, what's more important, or are they equally important? What, addressing a person's healthcare needs or medical needs in the moment, in that moment of interaction with the provider, or seeking to understand and address a person's social needs in that same engagement?
Well, I clearly think that even in a big metropolis city, knowing the cultural background of the patient, knowing exactly what their perspective is, that really helps in getting the rapport, but also saying, okay, how can I help this patient based on their socioeconomic status and based on their housing situation, based on that, for them to strive so that they will continue to get the quality care that they need for their complex medical situation.
Yeah. Emily, I recall during one of our conversations, you had some good insight into that question also. I didn't wanted to ask if you wanted to share any thoughts on that.
I think addressing social needs improves lives and health outcomes because it opens up a pathway to get healthcare professionals to understand that treating disabled people differently is not only unnecessary, but rude. Personally, I have felt like some doctors have treated me like a subhuman, and that takes a toll on disabled people's mental health over time. So, by addressing these social needs, It will hopefully improve disabled people's overall mental health.
Thank you for that,
Yeah.
Emily. And
I-
Carl, I think you wanted to follow up with something?
Yeah, just to piggyback off of what both Honora and Emily said, to me, that rapport is important. You have to treat people like they're human beings. That really that should be the first thing, to be honest. And then you start to dig into what the person's going through, what their medical needs are. And then, you do need to look at the social needs. In psychology, we have Maslow's hierarchy of needs that we follow. So we need to follow that, kind of all the way through. And, let's say somebody is homeless. We talking about readmission rates. If somebody's homeless and it's like the dead of winter, and you do application to the medical needs of the person, and then they, come out of the hospital and they're going back to being homeless, because everybody is not going to go to a shelter, and they have good reasons for that. Sometimes shelters are not, that safe or what have you. So they're out in the dead of winter, then all of a sudden they get pneumonia. They're coming back. Like the social needs, if they're not taken care of, that can actually lead to readmission. So to me, that's a sticking point for readmissions, because you can't handle one set of needs, throw people back into the same situation and expect a different result. That's the similar definition to insanity. Doing the same thing over and over again and expecting a different result. You're not going to change anything. So I do think that we need to look at this on the macro level and the micro level. Look at the macro, look at all the things that are going on, and then start to kind of dissect it from a micro level. So
Right.
that's kind of what I think about that.
Right. Thank you, Carl. And I'm going to be a little bit mindful of time. We have 10 minutes left in the webinar, so I want to leave a little bit of time for any questions for the audience. But before we do that, I wanted to ask your thoughts on your role in the research process, the role of individuals with lived experiences. What should researchers be thinking about? When should they be thinking about the perspectives of people with lived experiences?
I kind of think, because I definitely want Pam to tackle this, because I know we had some conversations the other day around this, but I kind of told you the other day that I think that there needs to be that team. There needs to be, from the doctor to the nurse to the social worker to the community health worker, and then even if you can get a little bit of friends and family involved. I think, again, there needs to be a coalition kind of, built around that person. And I think kind of like the packaging where something says it's disapproved. I think that everything we do around these patients needs to kind of be, I would like to see something that says lived experience approved, in that we are really looking at the lived experience of that person, and we are taking that into consideration, and we are not dismissing it, because there is a lot of value in lived experience henceforth while we're having this webinar today. But I really think that we need to kind of go 10 toes down and looking at the lived experience of people and using that to help them to get better and be better. And then I just kind of want to pass it along to Pam to kind of close that comment out.
Thanks, Carl. I hope that the participants can see that the four of us and Dawn, as well as Evelyn, have really had a lot of juice around this opportunity to speak, but also to take a deeper dive into looking at the data. And I guess I'm going to circle back to that point and say that there's expertise from many different perspectives. And if we could do better collectively in our research work by understanding and elevating the expertise of those folks with lived experience, particularly as we're speaking now with complex care, the robustness of the questions we would ask, the theory of change we would develop, the way we wanted to approach an evaluation. I think it would amaze us how beneficial that collaboration out of respect, out of relationship, would yield fruit. And we've been remiss in doing that. We really have, unfortunately, seen a hierarchy that has limited that voice of the lived experience. And we heard just in these past, half hour together in our dialogue that there's quite a difference in our individual community experiences and our medical experiences. But all of us have in common that we do want to promote health, our own health, the health of our healthcare systems, the health of our communities as a whole. And we need the bridge in order to pull together the diversity and the depth of experience so we can drive better decisions, better research. And hopefully, in our vulnerability, sharing with you some of the challenges we've had and also our appreciation that as researchers, as policymakers, as funders, that you'll begin to elevate that voice. And I think we'll all benefit from it.
And I know, Dawn, you have to kind of close this up, but I saw something in the chat that I thought was profound. I just love it. And it's from Cynthia Feaster. And she's saying, there's a saying, and I quote, "You must Maslow before you bloom," unquote. We must focus on basic needs to ensure good health outcomes. So I thought that kind of wrapped that up really well.
That is great. Thank you, Carl. Thank you, Cynthia, for that. Nora, Emily, do you have anything you'd like to share about your engagement or individuals with lived experiences engagement in research and policy making?
Yes, in terms of individuals with lived experience, we can provide the perspective to the academians, to the researchers. What is the focus? Make it like down to the nitty gritty. So for example, if the researcher was looking at Pamela's area, then it would be totally different focus than if we're looking here in Miami. And then to try to solve what is it that you're trying to do? You're trying to decrease homeless instability, make it specific to the area because, for example, if you look just at readmissions nationwide, it's going to have a different definition, different perspective. So from looking at individuals with lived experience participating in research, we can form like an advisory group and we can help design the research. We can help maybe look at the questions, look at what areas, and then also help in the evaluation, interpretation, and then eventually, hopefully, that research can help to lead some policy changes because we can say that, for example, in Pamela's area, this is what would be a good solution to work. In area where Carl lives, this is the situation, and also with Emily in her situation, in her conditions, that this would be the focus and how to really deal with that social situation. So our voice would definitely have an impact on the results of the study as well as any policy changes.
That's great, Nora. Thank you. Emily, would you like to add anything before we turn it back over to Laura Gottlieb?
I think individuals with lived experience should be the main focus in healthcare research. You can't research a topic without finding out about what main pieces make up the topic. Healthcare is about, or at least it should be about, serving patients. So, if people with lived experience are not being heard, then the research is useless, quite honestly.
Right. You summed it up, Emily.
Pretty powerful summary there, Emily. Thank you so much. Wow. I think we're down to our last minute or two. I'm sorry, let me just address one question that came in. Were there any qualitative components of the research study or plans for this type of research in the future? And that's a great question. And the short answer is no. For that initial research study, there were no qualitative components. I think there was some conversation about incorporating some qualitative methodologies into that research project, but trying to be pragmatic about the length of time of the study and the costs. We did not opt for qualitative methods, but certainly in the evaluation work we do now and any research projects, I mean, that sort of qualitative lens is critical. And if we were to do another RCT, there would most likely be a qualitative aspect to the research.
Amazing. I can't believe that hour went by so fast. I really want to just give a huge shout out to all the people at Camden who actually helped arrange this, had the idea for and arrange this webinar, which is so important and so helpful and so thought-provoking. And then tremendous appreciations to all of the speakers for bringing your insights and your personal stories and your incredible insights to this work. And then because I have to, I am just going to say again, if you are interested in kind of where healthcare's work is in this space, please continue to tune in to our webinar series. Our next one is on June 5th, and you can use this QR to connect. This webinar will be available. We will send the link out to all the registrants and make it available on our website. So more interesting insights, I'm sure, can be derived on the second round. Thank you so much for being here today with us, and everybody have a great rest of your day.
Thank you.
Thank you.
Yes, thank you.